what we're going to cover today. We're going to just go over what we mean by brain injury once again. That came up yesterday as a question, believe it or not, so we're going to just cover that briefly. We're going to look at some of the epidemiology, especially in pediatric brain injury, and the signs and symptoms that should prompt further evaluation. We're going to learn that a lot of brain injury in kids goes undetected, undiagnosed, and so we really need to pay attention to the signs and symptoms that should prompt us to investigate further. We're going to take a look at the prevalence and incidence of brain injury in kids, both here in New Jersey and nationally. And then I'd really like to describe for you a course, an ideal course of pediatric rehabilitation for brain injury. That course is something we have to strive for because it's not happening for a majority of kids injured today. So we'll cover that, and hopefully you'll go out from here and make that happen. All right, so what are the stats on TBI? These are new from the Centers for Disease Control, just published in March. If you ever want to know what the most current stats are, please visit the CDC website at www.cdc.gov. They are now updating their statistics every year on brain injury. It used to be they were only updated every 3 or 5 years, sometimes only every 10, but they have made a resolution to, because the data is there, they simply have to mine it and update it. So they're going to do that now on an annual basis. So as of March, we understand now that the new number is 2.5 million Americans sustaining brain injury every year. And that's traumatic brain injury. We'll talk about non-traumatic and how that's not counted the same way. We'll get an idea of the numbers of that. That number, 2.5, Barbara, what was it when you started? I think, was it 1.3 or 1.4?
It was lower.
It was definitely lower. And either there's more brain injury happening or we're counting better. Take your pick. I hope that there's less brain injury happening and all the efforts of the Brain Injury Alliance and the Brain Injury Association are working to prevent brain injury and that really we're just counting them better. But I don't know that for sure. So you can see the stats. The numbers of people dying actually have gone down. There's a 7% decrease in the number of deaths from brain injury over the last 10 years. The numbers of people who get hospitalized, which you can think of as people with moderate to severe injury. Most people with mild brain injury don't get hospitalized. So when you see a hospitalization number, think moderate to severe levels of injury. That number has increased over the past 10 years. It's up 11%. And the number who are treated and released from an emergency room, think of these as the mild brain injury folks. That number has skyrocketed and an increase of 70% over the last 10 years. So our management of brain injury, our ability for people to survive, especially horrific car crashes and falls, has the survivability has improved, but there are more people living with the effects of brain injury as a result. The numbers for children are all over the place, depending on how you count. So looking at children who were treated for sports and recreation-related concussions, 248,418 in 1 year. Again, an increase of 57% over the last 10 years. And we know that about 15% of people who have mild brain injury still have persistent symptoms after 1 year. Okay, so even though it's a huge number, it narrows down to a smaller number with persistent symptoms, yet if we don't follow those kids, we don't know which ones need help. And as a result, they get sort of subterfuged into other populations. Like in the school, they might be called learning disabled, emotionally impaired. They may get no help at all and drop out of school, God forbid, but that's often too often the case. The statistic here, 20 to 40% of people with mild brain injury do not seek any medical care. So that's a huge number, because remember, the number treated and released is the biggest part of that 2.5 million. It's really 75 to 80% of that number. And 40% of those people are not getting treatment. Pediatric brain injury is the leading cause of death and disability for children under 15. The most startling statistic for me that's now being put out by the Brain Injury Association of America is that 4.5% of the American population is living with a disability as a result of an acquired brain injury, which includes both traumatic brain injury and non-traumatic brain injury. 4.5% of the population. That translates to 13.5 million people. Okay? A much bigger number than if you go back and look at the annual incidence, 2.5 million. Well, these are the people that have ongoing, persistent problems as a result of brain injury. And it's a big number. It's a big chunk of the population. The cost of brain injury is, you see many different estimates ranging from 56, I've seen higher estimates than that, $56 billion a year. And that's really not just the cost of care, it's the cost of lost productivity. When you think about, especially young people, children, young adults having brain injury and then not being able to be productive as they had hoped to be, and to be able to earn money, pay taxes, and have a fulfilling life. So it's a huge number, and it behooves us to do as much as we can to help people with brain injury. I'm sure you've seen this one. Every 21 seconds a person has a brain injury, and we have some estimates on the number of youth that die from brain injury. Remember the total number was 50,000. Children and youth, about 7,000 of that. And you see other numbers here about hospitalization and long-term disability. The 33% number, that's surprising to me, because you might expect that only 15%, if you looked at those with moderate to severe injury, it's like 15%, and those are the ones you would expect to have long-term disability, right? But some of the mildly impaired people are also having long-term disability, and that's why that number is higher. It's very important to keep that concept in mind, that the level of impairment, or let's go back to the degree of injury, mild, moderate, or severe, doesn't always correspond directly with the level of impairment, which then doesn't always correspond directly with the level of disability. Those can all be variations. The highest rate of TBI-related emergency department visits occurs in the very young, the 0 to 4 group. Anybody got an idea why that is? 0 to 4. Falling. Why do kids fall? They're just learning to walk and run. And yes, that's when a lot of accidents happen. And also, a lot of times, if they're not being properly supervised, they're doing things that they shouldn't be doing that then cause them to fall and hit their heads. So, and then the next highest group is older teens, age 15 to 19. And what do you think is the reason for that? Car crashes. There's no such thing, by the way, as a car accident. They're called car crashes. Okay. I mean, what's an accident? These are motor vehicle crashes, is what we call them. Okay. Somebody's always at fault, right? Somebody. So they're not accidents. But yes, when our kids reach the driving years, this is where they're at the highest risk, because they're inexperienced drivers, or they're riding with others who are inexperienced drivers, and And this is where we see the next highest rate of TBI. So in New Jersey, according to the Department of Health and Senior Services, the Commission on Brain Injury Research, it's estimated that 12,000 to 15,000 New Jersey residents suffer brain injuries each year from trauma, of which 1,000 are fatal. Approximately 175,000 New Jersey residents are currently living with disabilities from traumatic brain injury. So that's the prevalence number, the living with number. Okay, that includes people injured every year, the cohort of those who are still living. In 2011, the New Jersey Department of Health Center for Health Statistics published that 1,346 children and youth aged 0 to 21 were hospitalized with brain injury. 34,880 were seen in emergency departments. And they were tracking an overall decrease in hospitalizations, but an increase in emergency room visits. No surprise, right? It becomes harder and harder to get hospitalized because we don't get reimbursed for that as much. But the implication of that is very, very important for everybody in this room, because you're more likely to be seen in the ER and sent home, and then the way to find services becomes much harder for families. Okay. And that's where organizations like the Brain Injury Alliance are so important, because getting the word out that we're here and that we can help families, that's who they should call, because they're gonna be discharged from the ER, and then lo and behold, there's where do you go next? Okay. The most important finding on this page, however, is that based on 2012 data, the New Jersey Department of Education counts only 767 students classified as eligible for special education under the TBI category. So what's wrong with this picture? We have 1,346 hospitalized. What did I say about if you're hospitalized? What does that probably mean about your brain? Moderate to severe injury. Wouldn't you expect those children to be at least ones that needed help for brain injury in school? The number was 1,346.
And we have 12 grades. Right?
Times 12, because that would be the prevalence number. So we really would expect over 15,000 kids to be classified, and instead only 767 are. So the National Pediatric Trauma Registry is a voluntary multi-institutional database that compiles data from contributing pediatric trauma centers and hospitals on children aged 0 to 19 who are admitted to the hospital for an acute injury. So again, this group that we're going to be looking at the stats from is probably children with moderate to severe injury. Okay, so the red is the male, the blue is the female. What do you notice just looking at that line, at those two lines? What's wrong with this picture? Males are still leading the way in brain injury. Okay? Not that I wish ill upon females, but I guess, especially look at where it starts, look at where those two lines start to diverge, right around what, age 12, 13? So what's happening at that time? Impulsive? Yeah. Adolescence. Hormones. Hormones are kicking in, right? And so it makes us guys do dumb stuff, I think. When they look at the mechanism of injury, this one was a little surprising to me, but again, remember it's 0 to 19, and this is for fatalities. Okay, so this isn't people living with brain injury. This is people dying from brain injury, and the most common way people die from brain injury is through firearm in that 0 to 19 And then the next biggest is motor vehicle traffic crashes. Falls is down there, so people aren't dying as much from the falls as they are from these firearm and car crashes. Now if we look at fatality rate by age in the 0 to 19 group, okay, so we see, this kind of parallels what we talked about before with the emergency room visits. The 0 to 4 is the highest, and then again there's a sort of a lull, and then the 15 to 19, again, it picks up dramatically. Starts to pick up dramatically like between 15 and 16 there. I think there's a lot of 15-year-olds riding around with their 16-year-old drivers, you know. That was certainly the case at CHOP. So the incidence and case fatality rate by mechanism of injury, okay, so the most common, look at the number column here, the most common number was actually falls here. It was higher. I don't understand the difference there. Was case fatality rate, oh, deaths, okay, so just look at the numbers, the number occurring by that mechanism, but the deaths are listed separately. So then, yeah, that makes sense, because motor vehicle crashes and firearm are higher. Firearm being the highest rate, the 12.01. And then if you look at it in terms of the type of injury that caused and where it happened, happening at home versus on the street or in a recreational event, the highest number is actually occurring at home. What's that telling you? Another big source that we haven't talked about yet. Domestic violence, abuse, okay? And it could include kids falling and stuff like that too, but I do a lot of work now in the prison system, and I'm involved with a project where we're actually looking at people who are about to be released from prison in the next 6 to 10 months, and we're screening them for evidence of brain injury. And guess what we're finding? 72% of people leaving prison have brain injury. And it's not just one brain injury, it's usually a series of brain injuries that usually begins in childhood, okay? Whether it be falls, car accidents, car crashes, assaults, including being abused by their own family. Okay, so we shouldn't be surprised by this, I guess, but I continue to be. This history of repeated brain injury starts in childhood for many of these guys, and we're documenting it, and we are actually using it to refer them to brain injury services, so that when they leave the prison, they are now going into either outpatient or residential or vocational services that they would never have gotten to otherwise, because these guys don't even know that they have a brain injury. We're the first people to tell them that they ever had a brain injury. Ooh, thank you. So I better speed up. Okay. Region of the body. So there's no big secret here. The head is the most common region affected. And then what kinds of protective devices have been used in most of these incidents? Well, the most common answer is none. Okay, that's 30%. And then you see seatbelts, shoulder belts, and helmets coming in, and airbags as the most common protective devices. But they're really down there. So there's still kids riding around without seatbelts on, even though all the public education that we have done about it, and still kids not wearing helmets. This slide is really disturbing to me, because this shows what happens to these kids after they are discharged, they are treated and discharged from the hospital. So 70% were sent home with no services. A much smaller percentage were transferred to another type of rehabilitation care, only 2.5%. Does anybody have any idea why that percentage is so low? Yeah, the resources really aren't there for the next step in the care that these kids need. So who pays for the hospital? Well, don't we all have health insurance now? The answer is yes, by the way, under Obamacare. Okay. So you should have hospitalization insurance. But does that follow then that you're going to have the kind of insurance or the kind of resource that you need for what's needed after the hospital? And oftentimes the answer to that is no. Okay? And when you think about it, there's actually a lot more resources out there for adults with brain injury than there are for kids with brain injury. So I work now in Pennsylvania, so in Pennsylvania we have a lot of resources for adults. We have the Office of Vocational Rehabilitation, we have a state trust fund head injury program, pays for up to a year of very intensive services. We have the ComCare waiver, we have the OBRA waiver, we have the independence waiver. We have a lot of help in Pennsylvania, and that's what we're hooking those prison guys up with. But when it comes to children, what is the major resource that children have after a brain injury, after they leave the hospital? It's their family and the school. Those are the resources that kids have, family and school. And are schools prepared to help a kid with brain injury?
No, especially if they're not aware.
Especially if they're not aware, right? The most important thing for us is to recognize that the group in this mild category, free for no loss of consciousness, who may be diagnosed with concussion, that concussion is in fact a brain injury, that you do not have to have a loss of consciousness to have had a brain injury. So just seeing stars, being dazed, confused, and being wobbly, and having initial symptoms, that is a brain injury. And what's happening when you present that way is there's a pathophysiological process going on in the brain that changes the way the cells are able to work in the brain. There's a disturbance in brain metabolism. Now, what do they do when you suspect a concussion? What's the normal course? Send them to the ER, right? What do they do there? Give a CAT scan. Well, lo and behold, the changes that we are seeing in the brain are at the cellular level. They're microscopic changes. They're not capable of being picked up by a CAT scan or an MRI. Okay? So the fact that the CAT scan is negative is not any cause for rejoicing, really. You still have to follow that kid and see whether the symptoms persist or subside. And that's really the best state-of-the-art practice at this point. So the old myth that concussion only occurs if you're knocked out is not true. And in fact, more than 90% of concussions do not involve a loss of consciousness. Do not. So here's your early signs of concussion and your later signs. The early signs you're all familiar with: headache, vomiting, blurred vision, ringing in the ears, dizzy, woozy, fatigue, maybe a stiff neck. Those usually subside fairly quickly, first week, 5 days, week. But what can be more disturbing is the later signs: slowness in information processing, emotional lability, crying for no reason, acting out of proportion to what's going on around you, reduced frustration tolerance, not sleeping right, and being overly sensitive to noise. What's not on there is having memory problems too. So the forces that happen in a mild brain injury are important to understand, and I'm just going to throw this slide up there so you can understand the wide variety of forces that are going on. There can be focal injury, diffuse injury. The type of force can be either contact forces or inertial forces. Inertial would be like, a football player driving forward. That's a direct translational acceleration that's going to cause coup injury, where the head hits the other player, and contra coup, where the brain bounces back and hits the skull. Inertial forces are rotational acceleration forces. So in a car crash, if you can imagine that you're the driver and you're texting, and you shouldn't be texting, and you run into the car in front of you because you didn't see that it was stopped because the car in front of it was turning. And you are wearing your seatbelt, your airbag deploys, but guess what? Before it can deploy, a brain injury is already set into motion for rotational acceleration, which can cause diffuse axonal injury. Even in the split second before the airbag deploys, you are rotating out of your belt. Your belt is holding your left shoulder in, it's not holding your right shoulder in, so your head starts turning from the force of the collision, and that brain keeps going inside the skull in that fashion, no matter what happens, airbag or not. So that we still see injuries, even with the airbag and seatbelt systems that we're using. And the thing about rotational acceleration forces, if there's sufficient force to tear apart a neuron, that same amount of force is sufficient to tear the tiny capillaries that bring oxygen to those neurons. So you're just as likely to see hemorrhage and little petechial hemorrhages. If you have diffuse axonal shearing, you're also going to have damage from anoxia too. So here's the coup contra coup that I just described: head bouncing, the head going back and forth, and the brain bouncing inside the skull. What this picture here is trying to do is show you. Pretend this is a skull with top shaved off, so you're looking down into the skull. This is where your spinal cord is going through. And you see this ridge right here, and here, and here, and here. These are called the bony orbitals. And that's what the brain is sliding back and forth over. It's really a bad design. Okay? It's a setup for contusion and hemorrhaging to occur. All right, so we've talked about most of this, but just be aware that it's, if you have sufficient forces, you can have tearing of the neurons. You're also going to have tearing of the capillaries. And a lot of the secondary effects that we try to prevent, this is showing you a case where this kid probably should have been scanned in the ER, because this is a big bleed up here that's developing. That you could see, because that's not microscopic any longer, it's huge. And that's going to cause significant frontal lobe damage. Okay, so that's why we do the CAT scans, is to pick up on stuff like that before it becomes that big. But other common results are ischemia caused by cardiac arrest or hypotension, seizure disorder, and increased intracranial pressure. These are all common secondary effects that need to be followed and treated immediately. And just so you understand what I mean by diffuse axonal injury, we're talking here about these microscopic cells, and the force applied to them is such that they can't sustain their integrity. Okay, so there's a little, the long part of the neuron cell is called the axon, and it's like a little tube that has a little slinky in it that props it up. It's called the neurofilament. And the initial trauma causes a breakdown of that neurofilament. It's like the slinky breaks, and then it starts to pull apart from itself. And this goes on over a couple of hours following the initial trauma, such that that cell is no longer able to sustain its structure, and it breaks apart and dies. Okay? And here's a picture of it under a microscope. You cannot see this on CAT scan. So this one's already dead. Okay? But here's a nerve cell that should be connected, just like these are, around it. And this one is forming the retraction ball and is no longer connected to the rest of its neuron. This happens within several hours from the initial blow. And this one over here, all these stain cells are healthy living cells. This one is dead. It's not taking up the stain. Okay? So this is to show you how it can happen to one cell but not a neighboring cell in the same region. And that's the nature of diffuse axonal shearing. During that first 7 to 10 days following the concussion, there's a terrific mismatch going on between the blood flow, which here is this tan line, and the demand for glycogen, which is the nutrients that the brain needs to work with. And you can see the mismatch period especially bad during the first 2 to 3 days, but things don't start to stabilize. These three lines need to come together, and it's not until about day 8. Okay? And that is actually when we start to see some of the initial symptoms subside. So there's a physiological explanation for this. Of course, you know about neurocognitive screening. This is what we're now doing in the prisons as well, but we are trying to get it done in schools so that we can actually take care of our kids the way we do the professional athletes. It's been around for a while, it's not new, but you know, every state has a concussion law now which really tries to get kids you know, the proper help if a concussion is even suspected. Okay? All of these sports have a risk for concussion, and really the athletes should go down even, you know, maybe even before age 11, you know, for kids who are playing contact sports. I show you this slide just to show the different realms of concussion. This actually comes from the impact studies out in Pittsburgh, where there are symptoms, the more somatic symptoms, the more emotional symptoms, sleep disturbance, and cognitive symptoms still persisting on the athletes that are measured on the impact scale 7 days after concussion. So things like attention problems, memory, fogginess, fatigue, and cognitive slowing, still showing after 7 days. So as I said, we expect these symptoms to subside within the first couple of weeks, yet many times they last for 6 months or a year, or longer. Many athletes recover fully, but it's really essential that we pull them from play, give them rest, and follow them with people who are trained in concussion to be able to know which ones are going to be able to do that and which ones really need additional help. So here's the things that we're most worried about in terms of post-concussion syndrome, the persistent symptoms, which, if not addressed, can turn into academic difficulties or, as was mentioned, behavioral difficulties. Okay. Now, let's just make sure we all know the other half of the population, besides traumatic brain injury, are non-traumatic causes of brain injury. And we know that this can happen from brain tumors. It can happen from the treatment we do for brain tumors. So surgery, radiation, chemo can also cause cognitive impairments. Anoxia or hypoxia. So near drownings, we had a lot of them, a lot of those kids in my unit at CHOP. Also, I'm hearing from the prison guys that there's this game where they try they try to simulate choking. I don't quite get the game part of it, but that can cause hypoxia as well. Infections of the brain, all kinds of infections, bacterial, viral. You have a kid who's totally fine one day, a good student in school, and the next thing you know, they're in the hospital with a viral encephalitis. And we never know what causes this. It can happen to anybody. I said already about stroke being caused by sickle cell or heart defects, and ingestion of toxic substances. So here, there's a lot of debate in our field about whether we should be including kids with fetal alcohol syndrome because their moms ingested toxic substances which went right through the blood-brain barrier to do damage in the fetal brain, but they technically don't fall in our population because acquired brain injury means you were born with a normal brain and then something happened to it. But these kids end up having a lot of the same problems as the kids with TBI. And they need some of the same kinds of help and support. So I tend to be interested in those kids as well. You know the cognitive effects of brain injury. We don't have to go over that. I just want to highlight the most critical one that doesn't get a lot of attention is prospective remembering. Do you know what I mean by prospective remembering? That's remembering to do something in the future at a certain time that you intend to do. So you have the intention of doing your homework on Wednesday, but come Wednesday, you lose the intention. It doesn't even occur to you that you had planned to do your homework on Wednesday. Okay? And that's a critical memory skill for adults and children, and we can help them with that. Okay? We have ways. Executive functioning, all of these problems that you're probably well familiar with are problems for kids with brain injury as well. And we have help for these things. We just have to identify the kids. Emotional and social effects, if you can't do things the way that you always used to do them, how would that make you feel? It's going to make you feel anxious. It's going to lower your self-confidence. You're going to think people don't like you anymore, and you're not going to understand the reason why. And that can be prevented if we surround the kid with the right kind of help. We even see, all of these behavioral and emotional changes happening after brain injury, especially apathy. If I hear one more time a parent or a teacher say, the kid's just not motivated, well, guess what? They have a frontal lobe injury, and it's not possible for them to be motivated the way that you're thinking about it, okay? I actually have banned the word for my staff. They're not allowed to use it, okay? They have to describe the frontal lobe functions that they're either seeing or not seeing, okay? Because the treatment is there. What do you do if you say the kid's not motivated? What's the treatment? Whip them into shape? So, if we really understand what's going on in the brain, we can offer these students a lot more help in the way that their work is set up, the way that their school program is designed, and the way that they advance throughout their school career. And kids who have brain injury are going to need support throughout their whole school career, not just a year or two, because every year the challenges are different for them. And in order to transition successfully into adult life and adult roles, they're going to need a lot of help and support. We try to do this. Every children's hospital tries to communicate with the schools and tell them, when I was a child, the first call I would make when I had an incoming kid was to their school principal. And I wanted to talk to the man or woman in charge because I wanted them to know they're going to get the student back different than they were before. And that we have to start the wheels in motion for how we're going to support that kid. And even with doing all of that, we do all of that and we still don't always get to the right result, as this lady pointed out. But I think the ways to get started are through neuropsychological evaluation and all of the other things that a child study team does. But really important here is functional classroom observation. This is something I call neurofunctional assessment. I teach our therapists how to do it. It really involves understanding the cognitive task demands of what's required of that student in that classroom. And you can't know that unless you go there and observe it, and you know the kids' strengths and weaknesses, and you can see how they're able to interact or not with the cognitive task demands. So neuropsychologists do the evaluations like Dr. Ross and myself, and that gives you a good baseline where the kid is in terms of strengths and weaknesses. But guess what? School systems don't usually have neuropsychologists. So if perchance the kid was in our hospital, but we couldn't do the neuropsych because their brain was still changing, as it often is during the first 60 days following especially a moderate to severe injury, then the neuropsych eval has to be done once the kid's home. Guess what? Sometimes that gets missed, and it's hard to get it done. The child study team is used to using educational assessments, but that doesn't always assess the capacity for new learning. They don't always get it. Memory, perspective memory, frontal lobe functioning, problem solving. And that's what we do as neuropsychologists. But it's important to have the whole team evaluate, and also including an assistive technology evaluation. It's now becoming a pretty standard part of what we do. So this functional classroom observation is so invaluable because it tells us what the kid can do. If we cue them, we can test the limits on the cueing right there in the classroom. We can see how they do with distractions, with a noisy environment. It tells us how we need to structure things. And we can actually test a lot of that out while we're right there in the classroom. These are the traditional things that are done for kids, modifications, giving them more time, different types of ways of presenting the information. What that's trying to get at is whether we can see if the information is learned but maybe not able to be recalled. Perhaps it can be identified, so we give multiple choice instead of fill in the blank. You know, there's ways to alter what's being asked for to demonstrate learning. Obviously there's things that we have to do differently with each kid depending on their strengths and weaknesses. So, and a lot of things we can do with their schedule and what courses they choose, and you know, so that we're leading them to their strengths and utilizing their strengths and not necessarily overloading them in areas of weakness. And the most important thing is working with the teachers, okay? Because really, rehabilitation in this stage is really about how the teacher instructs the student. And the teacher becomes, or the teacher's aide becomes, the cog rehab therapist. But they don't know how to do that. They don't know how to do that unless we teach them how to do it, okay? And right now we're doing it on a one-to-one, you know, this case, that case. There's not a systematic way that this is occurring. So these are some of the neurofunctional strategies that we use. Organization, checklists, you know, all of these kinds of things. I just wanted to share with you, because we only have a few minutes left, about a program that we do in Pennsylvania called Brain Steps. And by the way, all these slides will be available to you on the BIANJ website. So you can go to this www.brainsteps.net. It tells you what we're doing in a more systematic way in Pennsylvania. Every school has a Brain Steps consultant available to them to work with teachers in the classroom and to work with parents. That's done through the intermediate unit structure that we have in Pennsylvania for special ed. We don't have that structure here in New Jersey. Every school does their own special ed. So it's been a lot harder to implement this approach in New Jersey, but the ideas behind it you can still implement. So it's a lot of partnering with brain injury providers to try to get the interventions that we would do into the classroom and to make sure that students get that help to advance in their school career and then into adult roles. So you can see all the things we do in Brain Steps. The ideal is to do this in the kids' home school. That is the most desirable thing, not to pull them out, you know, because there's a lot of supports and natural supports in their environment. But if that doesn't work, there are special schools that can work with kids with brain injury. And I've listed two of them here. One is where, at my program at Woods called Connect Neuro Ed, where we have trained the teachers of the classroom. They're all CBIST certified, and they're trained in brain injury rehabilitation strategies and how to weave them into the educational programming. And the same is true at Garfield Park Academy, their Compass program. That's in Burlington, New Jersey. And we also trained those teachers to be ACBIS certified. So there are these special approved private schools that can help. So I just wanted to leave you with these final points that you know about the 13.5 million now, not a small number anymore, 4.5% of the population, and brain injury is the second most prevalent source of injury and disability in the U.S. What do you think is the first? Anybody? What?
You got a question?
Oh, brain injury is the second most prevalent injury and disability in the United States. What do you think is the first most prevalent?
Post-traumatic stress disorder. PTSD.
Oh, that's a good guess, but no, it's depression. Depression number one, brain injury number two. I don't even know where PTSD is. Well, thank you all. We'll end there, I think. Thank you very much.